So thanks to all the organizers for this opportunity. So this is a small review of a poster which was presented in ESMO by Solange Peters. So this actually is a kind of an interesting data set which looked at ctDNA dynamics to predict molecular response in patients receiving first-line immunotherapy and chemotherapy. So one second. Sorry. Yeah. So the objective of this trial was that, so this is just a subgroup analysis and of a trial of a first-line metastatic NSCLC trial wherein people, they evaluated the use of either durva alone or the double trouble combination of durva and tremelimumab versus chemotherapy alone in the phase 3 MYSTIC trial. So the methodology of the trial was that they actually included around 1,000 odd patients with this combination. And what they did is that at the baseline, they extracted ctDNA using the Guardant technology. And so they looked at the ctDNA as baseline. So that is what the sample was called, BEP1. And then the second sample was done either before the second cycle of chemo or IO or whatever they were taking, or before either the second or the third cycle of the chemo or IO. And they defined something called, so obviously this is quantified in terms of a VAF or a variant allele frequency. And so the percentage change from the mean baseline VAF was calculated, and molecular response was defined as a 50% decrease from the baseline mean VAF. And they estimated survivals and radiological response based on this criteria. So this is essentially how many patients were recruited. So at baseline, they had around 1,000 odd patients who were screened, and they had 932 samples. And then the BEP2, that is the second sample, was available in around 700 odd patients. And so for the first sample, around a third, around 300 each, were treated with durva or durva and tremi or chemotherapy alone. And similarly for the BEP2 for the second sample. So these are the curves for the plots of the OS. So I'll just take some time here, and what I'd like to show you is that so this is the OS based on the VAF at baseline, that is the BEP1 sample. So the red curve shows patients whose VAF at baseline was below the median, and the blue curve shows those who had a VAF which was above the median. So again, clearly across all arms, there seemed to be a better overall survival among patients who had a low baseline VAF to start off with. So especially more so, this difference is quite obvious in the arm which received durva, 16 versus 8 months, and in the arm which got the double combination, 12 versus 8.1 months, and in chemotherapy, 15.7 versus 9 months. So then moving on to the molecular responders versus non-molecular responders. So like I told you, molecular responders had more than a 50% decline in the mean VAF. So here, the median OS difference becomes more dramatic. So especially in the arms which got the immunotherapy. So patients who getting single agent durva was around 28 versus 10, the combination 27 versus 9, and the arm which got chemotherapy, there was not so much of difference, 12 versus 13.8. And also in terms of durable response, so they define durable responses as either a complete or a partial response which lasted for more than 6 months. So when these were compared, the odds for a durable response in patients who had a major molecular response were around 4.4 for durvalumab and 6.8 for the combination. And then when we look at when we look within each treatment arm, so the bar graphs on top are actually within each arm. So look at the one on the right, actually, where my arrow is pointing. So here we have the first 2 bars are actually patients who got durva, and the green looks at patients who have a partial response. The blue is stable disease, and the red is the progressive disease. So the first one is patients who got durva and who had a major molecular response, and then the non-molecular responders. So you can see that the proportion of patients who had response as defined by either a partial or a stable disease were higher among the patients who had a molecular response. Similarly, in the durva and tremi arm, again, the proportion of patients who had partial responses were higher, and also in the chemotherapy arm. Now, when we look at OS as in among patients with the best response is stable disease, again the striking difference as per the molecular response was there across the board in both the immunotherapy cohorts. That is a cohort which got Durva and Tremi, whereas this difference was not seen in the subset who got chemotherapy. So when we look at the results, so patients, it is very clear that patients who had a molecular response had longer OS versus those who didn't have a response, especially when they got either Durva or Durva and Tremi. And among patients with the radiological response at week 6, major responders were likely to have a more durable response, that is defined as a lasting response more than 6 months. And also patients who had a molecular response had higher partial response rates. They were more likely to have partial response than stable disease. And even among patients who had stable disease based as their best response, if you had a molecular response, you had a better overall survival, which numerically actually compares to that of the entire cohort. So now conclusions, baseline ctDNA definitely are prognostically associated with survival outcomes in lung cancer, irrespective of the treatment received. Now, in patients who got Durva or Durva and Tremi, molecular response was predictive of radiological response, and it also translated into a better OS. And also this kind of translated into a longer term survival and also a longer duration of survival. Now, for me, this is my last slide. So when I want to think about what I can take home, or rather what I can do tomorrow in the clinic. Now in India, I think immunotherapy is definitely not accessible for a lot of patients. And, this could be one way wherein we can, predict or judiciously use immunotherapy. And now this data is kind of exciting in the sense that among those who don't respond, maybe there are avenues to escalate treatments and to explore the options of NGS and mutation testing and so on, and or even thinking of doing getting them onto clinical trials. So I will stop here and thank you.